everyone, and welcome to the Farz Academy MRCP course once again. Today we will cover the glaucoma module. What is glaucoma? It comprises a heterogeneous group of diseases that have in common a characteristic optic neuropathy and visual field effects, for which elevated intraocular pressure is the major risk factor. Intraocular pressure, or IOP, is the key modifiable factor. Normal IOP is 10 to 21 millimeters of mercury. Glaucoma is the second leading cause of blindness worldwide. This is the anatomical difference between open and closed-angle glaucoma. In the top part, we see the view on anterior segment OCTs, and in the bottom part, the view on gonioscopy. First of all, primary angle closure glaucoma, also known as PACG or acute glaucoma. Angle closure refers to occlusion of the trabecular meshwork by the peripheral iris, obstructing aqueous outflow. The symptoms of primary angle closure glaucoma include dull pain, which may radiate in the fifth cranial nerve distribution and may be associated with secondary watering, blurred vision, colored halos around lights, light sensitivity, frontal headache, sweating, bradycardia, nausea, vomiting, and even abdominal pain can be present. This can be misdiagnosed as an acute abdomen, so beware and take note. The signs of PACG. It presents with an acute painful red eye. This can be given as a question in your exams. A 65-year-old male patient presents to the emergency with an acute red eye. What is the likely diagnosis? The signs include eyelid edema, conjunctival hyperemia, corneal edema, that's haziness, closed angle in the involved eye and a narrow angle in the fellow eye, fixed oval mid-dilated pupil as seen here, and elevated intraocular pressure, sometimes as high as 70 millimeters of mercury. Now to consider primary open-angle glaucoma, also known as POAG or just open-angle glaucoma. It is the commonest type of glaucoma and the most prevalent type of glaucoma in people of European and African ethnic origin. In open-angle glaucoma, there is a gradual increase in resistance through the trabecular meshwork. This makes it more difficult for aqueous humor to flow through the meshwork and exit the eye. Therefore, the IOP slowly builds within the eye, and this leads to a slow and chronic onset of POAG. This video shows the production of aqueous humor from the ciliary body and the outflow. So, formed from the ciliary body in the posterior chamber, aqueous humor coming through to the anterior chamber, draining out through the trabecular meshwork in the angle of the anterior chamber. And this shows how cupping occurs. So when there's increased intraocular pressure in the eye, gradually the tissue of the optic nerve or the optic disc is destroyed. The high-risk groups for POAG include family history of glaucoma, individuals above the age of 40 years, those with myopia, diabetes mellitus, hypertension, migraine, or those taking steroids, Black ethnic origin, and abnormal optic nerve anatomy. Open-angle glaucoma is a particularly dangerous eye disease because those who have it don't know anything is wrong until significant irreparable vision loss occurs. This is because in its early stages, POAG has no symptoms, no pain, noticeable vision loss, or other hints that something is amiss, prompting the name silent thief of sight. So remember, POAG can be asymptomatic initially. Symptoms can include seeing rainbow-colored halos around bulbs, frequent change of presbyopic glasses, headache, and eye ache. To elicit the signs, gonioscopy is done to assess and grade the anterior chamber angles, and this is the view seen. This is how the intraocular pressure is measured, and this is what we can actually see. The fluorescein stained tears form two semicircles, the inner edges of which just touch. Fundal examination is required to check the optic discs, and we can see a normal and a glaucomatous disc in this picture. Visual fields or perimetry are done to check for peripheral field loss. These are the typical glaucomatous visual field effects, and this is a standard automated perimetry printout for someone with advanced POAG. Optical coherence tomography or OCT scans have become an important tool for the clinical evaluation of the optic nerve and retina. Disc or RNFL, retinal nerve fiber layer OCTs, are important in early glaucoma. There are other more advanced tests like anterior segment OCT to assess the anterior chamber angle and UBM or ultrasound biomicroscopy. Central retinal vein occlusion, or CRVO, is most common in elderly patients. You may be shown a picture of a typical stormy sunset, but remember that this may be secondary to glaucoma or POAG. There are multiple systemic disorders associated with raised intraocular pressures. We will be covering some of these which have been seen in your examinations. And there are plenty. Medicines causing glaucoma. Glucocorticoids administered systemically, topically, or intravitreally are known to increase intraocular pressure, which can lead to the development of open-angle glaucoma in susceptible patients. Topical steroids are most commonly implicated, so it is important to advise against self-medication with steroids. Anti-cancer agents can also cause POAG. Several classes of drugs, including parasympathetic antagonists or sympathetic agonists, including inhalers, motion sickness patches, and cold/flu remedies, adrenergic agonists, cholinergics, anticholinergics, sulfur-based drugs, SSRIs, tricyclic and tetracyclic antidepressants, anticoagulants, and histamine H1 and H2 receptor antagonists have been reported to induce or precipitate acute angle closure glaucoma, especially in individuals predisposed with narrow angles of the anterior chamber. Pyramate is an oral sulfonate medication primarily used for seizures, migraine, and neuropathic pain. It has been associated with secondary angle closure due to ciliary body effusion, which can mimic acute angle closure glaucoma. Suspicion for medication-induced angle closure glaucoma should be higher whenever angle closure presents bilaterally. Thank you.